welcome everyone. Those who have joined, we have the number is slowly growing, so we're just waiting for a few minutes, about 1.5 minutes now, to start. Please, keep your video on if your bandwidth allows, but mute when you're not speaking. I think I can start with the housekeeping bits so that those who are on don't get bored while we're waiting for others to join. We can also put some of these in the chat. So again, welcome to this Africa Cancer Research and Control ECHO. My name is John Black-Kabuche. I am a medical doctor and health informatics specialist at the Uganda Cancer Institute. And today we're co-chairing this session with Benda, who is also the chair of the committee. So today's session will be about cancer care and cancer management in low and middle income countries, specifically looking at the topic of addressing access and affordability of essential cancer medicines. I don't know, I think most people who are here know how the ECHO sessions go, but these run now every month, and we do have people from different backgrounds, researchers, clinicians coming to present and share their experiences. The session is online as it is today. I already mentioned that we would want to see your faces, so turn on your video if your bandwidth allows, but please mute so that we don't get a lot of interruptions and background noises. There is a chat function that you have access to. Please use that to ask questions, to introduce yourself, to share any resources, and make comments to the presenters. If you need subtitles, you can enable that on your screen, and maybe you can follow if you are having trouble hearing the speakers. Remember that the sessions are recorded, and the link will be shared for those who have attended, so you can also see the previous sessions that we've held. I think I will also tell the objectives of today's session, which I mentioned is around access and affordability of essential cancer medicines. And we want to discuss the selection, prioritization, and procurement of the WHO and national essential medicines for cancer. And I hope there's clinicians on this call, like myself. We want to see how you can be involved in the decision-making process, because often some of the things are done at Ministry of Health level, at sort of high level, and you don't feel like your thoughts are represented. We also want to look at some examples of how to implement the process to facilitate access to medicines at the point of care. We have a very exciting team of speakers, and the session will go in about 15 minutes of a didactic presentation from Dr. Yehoda Matei from University of Pennsylvania, and then a case presentation of about 15 minutes from Dr. Chotlo Larifara. I hope I've pronounced that properly. He's from the Ministry of Health and Wellness in Botswana, and then we'll do a bit of a discussion after that. I'm checking to see if we now have good quorum. I think we are fairly there. So I'll go ahead and introduce the speakers and then hand over to them. So we do have Dr. Yehoda Matei, who is a medical oncologist, an assistant professor of medicine and the vice chief of diversity, inclusion, and health equity in the Division of Hematology Oncology at the University of Pennsylvania. She's a global health scholar at the Center for Global Health and a senior fellow at the Leonard Davis Institute of Health Economics at UPenn. And she is also an adjunct lecturer at the University of Botswana, where she conducts most of her research related to access to essential medicines for cancer care. Her research has focused on implementation of strategies for eliminating global disparities in breast cancer outcomes by optimizing high-quality breast cancer therapy in low and middle-income countries. And she has previously served as a steering committee member for the selection of the World Health Organization list of essential cancer medicines, and currently serves on the scientific advisory panel for the medicines patent pool, the Access to Oncology Medicines Coalition, and the Medical Advisory Board of the Max Foundation. She did her undergraduate and medical degrees at Harvard and Yale, respectively, and completed her internal medicine training at University of California, San Francisco, before going to UPenn. So welcome, Dr. Mate. We're very happy to have you, and we're really looking forward to your expertise, both from the US side and also from the African side. The next person we have on the panel is Dr. Refala Tlotlo, who is a clinical and radiation oncologist and the head of medical oncology department at Princess Marina Hospital, which happens to be the largest tertiary referral hospital in Gaborone, Botswana. Her department currently provides care for over 85% of adult oncology patients diagnosed in Botswana, and admits has over 3,600 chemotherapy infusions per year. So her primary research focuses on implementation science projects with a view to improve access to quality cancer care. And she has special interests in reducing cancer disparities across common cancers in Botswana, including breast, head and neck, prostate, gynecological, and GI cancers, and lymphoma. She's also the co-principal investigator on Project Automate Chemotherapy Ordering by developing and piloting electronic drug ordering. This is an area that I'm very much interested in myself, as I do work in digital health. Welcome, Dr. Tlotlo. We are again very happy to have you and looking forward to hearing your expertise. We're also glad to have Dr. Mary Nyangasi from the National Cancer Control Program at the Ministry of Health in Kenya. And again, Dr. Nyangasi has been instrumental in cancer policy formulation, establishment of cancer screening programs, regional cancer treatment centers, and various programs in improving access to cancer medicines in Kenya. That will be the panel, and myself and Dr. Benda will be facilitating the session, as well as Mishka. So without further ado, and I think we have almost everyone on the call. Well, some people can join. So please, Dr. Yehoda, please start your presentation.
Thank you so much for the introduction. So I will spend the next couple of minutes talking about sort of the first objective, which was really thinking about selection and prioritization of essential medicines. And I think that would give us sort of the language and the framework to then delve into a discussion with Dr. Alifala and Dr. Nyangazi and all of you joined here. And so, cancer care and management is really a broad topic, but I'll be focusing more on the medicines part of it for this morning's talk. So this is not an audience that I need to really convince that cancer burden is increasing in LMICs, but in summary, we know that over the next couple of decades, the burden of cancer in terms of number of cases diagnosed is going to increase and increase disproportionately in less developed countries compared to more developed countries. However, we know there's a huge cancer medicines access gap. So even though currently 60% of cancer cases are diagnosed in low and middle income countries, only 5% on global cancer spending occurs in these regions, which represents an enormous gap. It's like more than 50% difference in terms of how we allocate funding for cancer management. I like this framework a lot in thinking about access, because I think when we think about access to essential medicines, it's important to think about what components actually influence access to medicines. And so I think importantly, it's important to start with thinking about rational selection and use. And so medicines are important and essential based on what indication we think they're being prescribed for and why that's relevant. Thinking about affordability is important, sustainable financing and reliable systems. And so I'm going to talk a little bit more about the affordable piece of it, and then also the rational selection and use. So principles and methodologies for essential cancer medicine selection. And for this, I'm just going to focus really on thinking about principles and methodologies for the WHO EML for cancer. So the concept of essential medicines. So, essential medicines are a limited range of carefully selected medicines that leads to better health and better drug management and lower cost. And by definition, essential medicines should satisfy the priority healthcare needs of the population. And so I wanted to stress the bit about satisfying the priority healthcare needs of the population, because I think even though the WHO EML proposes a list of medicines that are considered essential, when it comes to prioritization of national EMLs, it's important that that list that we put together within individual countries are actually reflective of the priority within the individual countries. So for instance, they're like new melanoma drugs that are included in the EML at the WHO EML level. When countries are thinking about any EML, it's not necessarily important that every country thinks about medicines for melanoma, but really prioritize it to what your healthcare needs are within a specific population. And so just in terms of a brief background about the WHO EML. So the EML was first published in 1977. And at the time, there were 6 cancer medicines on the EML, which is just incredible to even think about, how few medicines were on it at the time. And then it underwent intermittent revisions every couple of years, but not in a systematic way until 2015. And so in 2015, UICC, along with a working group that was headed by Larry Shulman, underwent this process of really thinking about how we include and prioritize medicines on the WHO EML for cancer. And this led to really a huge expansion of medicines on the EML. And so there were 42 cancer medicines on the EML after that 2015 revision. And I think it's important to also note that prior to that revision, all the medicines previously included on the EML were generics. They were like generic cytotoxic chemotherapy. But in 2015 was when there was the introduction of medicines that were newer targeted therapies. Because in thinking about priority medicines, it was important to think not only about cost, but thinking about newer therapies with high efficacy. And so since then, the list has been revised every 2 years, and the process for which the medicines are included and prioritized has changed slightly over the last few revisions. But I think the core component remains the same, in that there is a need to actually think about how we prioritize medicines based on public health burden, and then also based on the efficacy of these medicines as well. And over the years, as the list has expanded, there's been an expansion of medicines that are considered targeted therapy or newer therapies that are patented. And so the issue of cost, even though was an issue previously, is now more prominent as we think about essential medicines list for cancer that now contain immunotherapies and targeted therapies that are expensive to even consider in a lot of LMICs and in parts of sub-Saharan Africa. And so this is a schematic that I like in thinking about how we weigh treatment goals and public health burdens in terms of prioritization of medicines for EMLs. And so like I said, I think when thinking about access or EML selection, it's important to think about rational use and selection. And so it actually starts with thinking about the cancers, then thinking about the therapies for the cancers. And so this is a paper that I think it's in press or just published electronically now in the Lancet Global Health, from this working group that updated the 2021 EML for cancer. And in thinking about medicines to be added to the EML, it's important to think about how we prioritize like specific cancers. And so on the x-axis is thinking about incidence of disease. So how common is this disease in your population? And so diseases on the right side of that x-axis are diseases that are very common. And so in a lot of African countries, early stage breast cancer and colon cancer, metastatic prostate cancer, these are all common cancers that we see. In places where HIV is prevalent, put Kaposi sarcoma somewhere on this list as well. Cervical cancer is probably on the higher end of the x-axis as well. On the y-axis is thinking about treatment goal. And so sort of the higher you go, the more you go from palliation, so with a small survival benefit, to actually treating for cure. And so in thinking about disease areas to prioritize, we really want to think about diseases that have a high incidence, so sort of far out on the right of the x-axis, and then far up on the y-axis. And so those diseases will be like early stage breast cancer. And so when you reflect on the 2015 list, you'd see that early stage breast cancer and medicines for early stage breast cancer were prioritized in terms of addition to that list. And so I think it's also important that when African countries think about NEMLs, it's important to have not this exact schematic, but to use this as a way to think about what your priority medicine should be. I think it's a bit idealistic to think we can cover, cancer treatment for all cancers, including diseases like metastatic prostate cancer, which are right in the corner here on low and palliative small survival benefit. And so, I think when, and Dr. Nyangazi and Dr. Relifalo could reflect more on this in the Q&A, but I think when we're thinking about what medicines to prioritize, it's important to start thinking about this area where there's early stage breast cancer. I'll probably put cervical cancer here as well, since it's the most second or first most commonly diagnosed cancer in a lot of African countries. And I think as you get good at covering sort of the diseases on this end of the spectrum, then you can think about broadening this a little bit more. But I think it's important to have some framework to think about this. And I like the schematic, and I think can be applicable in different settings and has been used in the WHO EML selection. And so when you think about the list, there's really no medicines that are currently recommended for the treatment of metastatic pancreatic cancer for these same reasons. So even though I'll be talking about affordability in terms of access to medicines, I think it's important to think about access more broadly. And I like this framework because I think affordability is just only, one domain of access. And I think if drugs were affordable, would increase access to a lot of these cancer medicines. But it's important to consider that in addition to affordability, that setting key criteria that actually influences how patients are able to access care for cancer and how they're able to access quality care for cancer. And so this framework is important. I just wanted to mention some of the terms. And so thinking about approachability. So, what is the health literacy of the population? Do patients even know what is available in terms of cancer medicines and cancer treatment and what the intent of cure is? Are patients accepting of these medicines? And so you could have, the best surgical oncologists and the best medicines, but if there's social norms that influence how patients perceive these interventions for cancer therapy, then even if you make them affordable and available, patients are not necessarily going to access them. And then there's also the issue about availability and accommodation. And so that has several dimensions. I mean, stockout is a common issue, and I think Dr. Relifalo is going to talk a little bit about that. But then there's also the issue about how available are these cancer centers for to patients in a lot of sub-Saharan Africa. A lot of our cancer care in sub-Saharan Africa is actually very centralized for cancer. And so in Botswana, patients have to travel 400 kilometers to get to their infusion appointment. And so in thinking about access, even though affordability is one piece of it, like availability of proximal healthcare centers that can provide cancer care is important. There's also the issue of, in addition to affordability in terms of direct cost of the medicines, there are the associated indirect costs. And so even in places where cancer medicines are available through a universal healthcare coverage system, the associated costs like transportation to get to the clinic, associated costs related to overnight stays because you traveled 400 kilometers to get to the clinic. And so I think these are all important when we're thinking about indirect costs. And cost of medicines is just a small piece of the comprehensive cost related to cancer care delivery. And then appropriateness. Appropriateness really relates to the adequacy of therapy. And this is where we think about things like, even when patients get therapy, are these therapies quality assured? Are they quality therapies? Are they getting adequate therapy? And so are they getting, for instance, if you're supposed to get Q21A 21-day treatments? Are they getting it on time as prescribed? And so these are all different components of access. And so I'm going to focus on affordability, right? We just wanted you to have that framework in mind that affordability is just not all encompassing in terms of addressing access to cancer medicines or cancer care. So I think a lot of you here probably know the data or are familiar with the data based on your experience in working with in sub-Saharan Africa. But I think it's important to just reflect on some of the quantitative data from the research literature. And so this was a survey that was conducted by ESMO, and it was to look at the cost and availability of cancer medicines. So specifically, I'm showing you the heat map that addressed cost of cancer medicines. And so they evaluated how much patients are paying for cancer medicines through a cross-sectional survey. And so shades of blue and green basically mean that patients either receive the medicines for free or are paying less than 50% out of pocket. In yellow, yellow means they basically pay more than 50% out of pocket, but less than 100%. And then red is basically paying the full amount out of pocket. And so that's the key. When you look at this table or heat map, across on the top row is a list of different cancer medicines. And these are all medicines that are actually included on the WHO EML. So you see anastrozole, bleomycin, capecitabine, blah, blah. And so these are all medicines that we're familiar with that are the backbone of a lot of the cancer treatments that we give. And then in the first two columns are the different countries that were surveyed, and these are grouped by income status. So high income on the top, upper middle income, lower middle income, and low income. And so what is clear at looking at this heat map is that when you look at high income and upper middle income countries, there are a lot of shades of blue and green. So essentially saying that a lot of patients in these countries either access the drugs for free or are paying less than 50% out of pocket. And this is not really addressing, disparities within countries, but just sort of saying that broadly, patients in these countries tend to pay, less than 50% or have these drugs available for free. And then you think about affordability and lower middle income countries and low income. And this is where you see a lot of African countries sort of embedded. And so the countries like Ghana and Egypt and, a few of Sudan, a few African countries, Zambia, that were surveyed here. And in these tiers of lower middle and low income countries, you see that there's a lot of yellow and red. And so a lot of the patients in these countries are actually paying for the medicines, either full out-of-pocket payments or greater than 50% of the cost of medicines. And so, it goes to say that these represent catastrophic costs for patients who are diagnosed with cancers in these respective countries, with a lot of these lower middle and low income countries being patients from Africa. We conducted a study where we got a little bit more granular and looked at medicine prices variation for pediatric cancer medicines. And so this is just a sample to illustrate just how varied medicines are priced across different regions, and to say that sometimes patients or governments in upper middle income countries and low middle income countries actually tend to pay more for drugs than in high income countries. And so this was a survey where we surveyed a couple of countries in different income groups across the world. And so high income, upper middle, low middle, and low income countries. And we looked at the prices of specific medicines. So these included generic cytotoxic medicines as well as patented medicines. Just want to give you an example of doxorubicin and ifosfamide. And so we asked the individual representatives from the countries to give us an estimate of how much they're paying for procurement of a 50 milligram vial of doxorubicin, for instance. And so when you look at this, you'd see that, in high income countries, the median price, the purchasing price per the adjusted prices for doxorubicin was 37.49 for this vial. But it's much more expensive in terms of the median price in upper middle income countries, and low, middle, and low income countries are paying, about the same as these drugs. So these are the originator prices. So these are the brand names. And then when you look at the generic prices are cheaper in general, and that makes sense. We expect generics to be cheaper than the brand names. But then you look at a drug like ifosfamide. Again, it's cheaper, median price is cheaper in high-income countries, more expensive in upper middle and lower middle income countries. And then when you look at the generic price, it's not sort of uniformly cheaper. It seems to be more expensive in some high-income countries. And so this is just to say that even though we're going to have a really interesting discussion about affordability and price of medicines, there's just so much opacity and lack of transparency in the process that it's created so much variation across different income regions in terms of how much governments and procurement agencies are actually paying for these drugs. And so I wanted to talk a little bit about what it even means and what the process looks like for procurement of these drugs. Because I think when you think about the multiple steps that occur in procurement, it helps you understand how at each step of the process, prices can be elevated or inflated. And so in thinking about procurement, and this is really thinking about what happens in most sub-Saharan African countries, there's usually a central medical store or some other entity, similar entity that will forecast medicines. And this can be based on actual consumption data. Sometimes this is a little bit more arbitrary, but essentially this agency comes up with quantities needed for specific medicines. There's usually a tender committee that invites bids, contract is awarded competitively, and then suppliers start to work with manufacturers to actually procure these medicines. And even though these are like same length arrows, this process where contracts are awarded to when drugs become actually available in country is very prolonged in some cases and can take 6 months, sometimes up to a year. But when you think about it, each African country is doing this process individually. And so there are a lot of inefficiencies in that process. And then this, is a diagram that I thought was really helpful to think about how complicated and how complex the supply chain is once drugs become available in country. And so this is really looking at public sector, private sector, and NGO procurement. And so in Botswana, where I work, like procurement agents work with the central medical stores to get the drugs in country. And then the drugs end up in regional medical stores. Because cancer care is very centralized in Botswana, all cancer medicines really end up at Princess Marina Hospital. And then the drugs eventually get to patients. The reason why I show this is because I also want to talk a little bit about pooled procurement, because what is happening now is that each African country is basically engaging in this procurement process individually for its patient population. Also, the number of medicines that we are forecasting is also very, is for limited. So a few things I wanted to address. So there's the procurement process, which relies on good forecasting. So there are a lot of deficiencies with the forecasting process in that a lot of it is not based on actual demand. Also, when we forecast medicines, we tend to focus medicines for 6 months to a year. And really, there is now emergent data from other regional procurement agencies that forecasting for 2 years takes advantage of economies of scale and can actually result in lower price reductions. So this is a slide actually that I borrowed from, I don't know how many of you were at the World Cancer Congress, but Christopher Lim presented on this, talking about the PAHO Strategic Fund and the pooled procurement process. And there are a lot of benefits of pooled procurement. There's sort of the efficiencies of it, the quality assurance of it, but then the huge part of it is also the cost reduction of it. And so this is a slide that he presented showing, this is actual data of how much individual. So on the left here is trastuzumab cost for a 440 milligram injection vial. On the x-axis is showing countries and how much each country was procuring this drug for. So you see sort of the variation in terms of how much individual countries were paying for this drug. So this is all within the same region, but countries procuring individually prior to pooled procurement, we're all paying like a wide variation of prices for the same drug. But then with the pooled procurement, this is like the much reduced cost that is being procured for this vow for the benefit of all countries within the region. And I should say that there are now 54 entities within the pooled procurement system. And so by pooling forecasting quantities from different entities, you're able to actually significantly reduce the cost. And so if you think about country one procuring individually for 5,000 and now being able to procure through a pooled mechanism for 445, that's a huge reduction. And then similarly for docetaxel as well, you know, huge variations in how much countries are procuring for an 80 milligram injection vial for docetaxel. Again, very wide variations, but much decreased price reductions with pool procurement. So I think, I'm not going to go much into universal healthcare coverage and NCCPs because I think we can discuss a little bit more about that in the discussion section and with Dr. Nyangazi, but I wanted to highlight that there are really exciting initiatives that are in place and being built to increase access to cancer medicines, notably the Access to Cancer Medicines Coalition, which is really bringing a lot of stakeholders together that are already doing some aspect of access to medicines in this area. And so bringing everyone together to actually develop global initiatives to increase access to medicines. And so this is exciting, still in the early stages, but I think it's something to look out for. And then also there's the WHO Global Initiative for Cancer, childhood cancer, which is also being implemented, or rather in the planning and implementation stages, to increase access to cancer care globally for childhood cancers. And I am going to pause here. Thank you.
Thank you so much, Dr. Ehoda. This is, very informative. I hope everyone is enjoying and learning from this process. It's quite complex than it appears on face value. We will go now to the next speaker, who will give a sort of a case scenario from Botswana. So over to you, Dr. Tlotlo.
Is Mishka there to share my slides?
Oh, yes, I can do that. Give me one moment here.
Thank you.
Is this the correct view, everybody?
Yes, that's what.
It's showing the presenter there. Oh, showing the, yeah.
Is that better?
Yes, that's good.
Okay. Thank you. I'm Tlotlo. Thank you for having me at this session. I'll talk a little bit about our experience in terms of cancer medicine access in Botswana, which will also speak to some of the things that Dr. Matei spoke to just earlier on, looking at what we could improve on and what we could potentially work on together as a bigger region. Thank you. Can continue. No disclosures. Okay, so where are we? We are Botswana, we are a landlocked country. We have 2.4 million people. We are in Southern Africa, and just like any other low middle income countries, we're definitely affected by non-communicable diseases, including cancers. And what we also see is that most of our patients come in at late presentation. And what we've seen now in Botswana is that by 2020, Global Care actually reported that we had about 2010 new cases, and we lost the more than half of that number of that patients. So more than half of them demised from this disease. We commonly see cervical cancer, breast cancer in the country, and also prostate cancer and colorectal malignancies. Now, what I want to point out is that the government of Botswana actually offers free healthcare to all its citizens, of course, including cancer management that looks at systemic therapy, surgery, radiotherapy, for instance, and more than 80% of the Botswana Essential Medical List actually has WHO cancer medicines in it. We can continue. That's where we are. How then does this work practically on ground? Yes, we do have a regulatory body in country. It looks at quality assurance, of course, and registration of medicines, plus other things. But now when you look at registration of medicines in the country, it can easily take to more than a year or even more than that. If we don't have any agent in the country and we need it, we can get an exemption. It is supposed to take about 48 hours to get this, but practically it can even take more time than that, even up to a month. Of course, they look at different things, like do they have all the certification available from all the manufacturing companies or not, or even the people, the suppliers on ground. So yes, there is a body, but it varies on how long it is that we can have access to a drug in the country per time. We have a central medical stores, as Dr. Matei said. This is where we get bulk procurement of our medicines, and it's usually at a cheaper price. And we provide medicine for all healthcare facilities in the public sector. Procurement is via different companies in the country. It's never with a direct manufacturer. And this will then speak to some of the delays that we will experience when we're now talking about having medicine in the clinic. So there's different things like the tender processes. Have we satisfied all the legal requirements, for instance? After all of this is awarded, do we even have the medicines on ground, or does the supplier on ground have to get it from elsewhere? So, you know, it's a process that already mentioned can take quite a while. I think, yes, I've said it's more than 3 months, but I'm definitely sure it can be more than that. Thank you. Then what happens if we don't have any medicines at the central medical stores? There's a couple of things that we do at the facility level. There is one that we call an emergency micro procurement. The only issue with this one is that you can only spend about $10,000 per time, and this is very little. Now imagine if you're trying to get so many different chemotherapy agents at that point in time because you have stock out. It is not a very sustainable or even efficient way of trying to get medicines. And what I must also mention about this is that usually the medicines would be quite expensive then. I mean, of course, because it's not bulk procurement, for instance. This can take about 2 months, all the way from you come up with a list of the products that you need. It has to go through procurement offices. You have to float RFQs, requests for quotations, for instance. You have to evaluate those. And then after that, you can award it to one of the companies. But then when are you going to get the medicine to the chemo clinic? Good questions. Thank you. Then what does this mean? I started off by saying that the government of Botswana offers free care to everybody. But you know, it's a lesson that I've learned just recently, that although there might be funding available, it doesn't mean that your patient is going to have that medicine the coming week, the following week, you know. What happened, I'll just give a little bit of a story or my experience. At this point in time, we are experiencing quite a lot of stockouts in our clinic. And of course, we've had discussions with our policymakers, and there has been funding that has been availed. But then suddenly you learn that as a clinician, then you learn that, oh, just because this money doesn't mean I will have these medicines in the clinic the coming week, for instance, right? Then you start learning that, oh, we have to float RFQs. We have to see if there's even anything available on ground. And you see that money can be there, but there's a whole lot more that goes into play just to have medicines. We've just had the experience of the novel COVID-19 pandemic. Could this maybe be the reason why we are seeing even more delays in getting some of the medicines on ground? Or could it also just be that perhaps we could have looked at how we forecast our medicines and maybe even have had quite a lot of our medicines for common diseases in bulk in the country, even maybe before then or even now, I do not know. So this means that we have quite a few changes then in our treatment plans for our patients, and it causes quite a lot of emotional distress. I mean, a lot of times we say that it would be the patients that are distressed, which is true, yeah. But then the healthcare workers are also distressed. I see it in the clinic. It's a painful thing to keep saying to the patient, oh, I don't have this at the moment, you know. And I see them when they come in, I see them when they leave, and I can tell that this is actually quite emotionally taxing. Thank you. Now I'll just give a short case presentation. I just recently saw a 40-year-old female with breast cancer. She had a big lump on her breast with skin involvement and some glands in her armpit. She didn't have any distant metastasis, and we deemed her curative. She had a normal heart study, and of course, then we offered her a treatment plan. These were the agents that she was going to get, and then post that she was going to have her surgery, her radiotherapy, and continue on with hormonal therapy. Thank you, Mishka. Thank you. So we gave a neoadjuvant chemotherapy just to make this the breast lump smaller, so we could totally removed the cancer with the surgery. She started this on the 15th of June of this year. And by the 2nd of November, she had had 4 cycles of her initial protocol with very good response. I mean, I saw her and the breast wound had already closed. Now she had to be started on a different agent. In our case, it would have been partly Taxol plus the trastuzumab, but she couldn't get this because it was out of stock in our facility. But what I also noticed at that point in time is that it wasn't just out of stock in our facility. We didn't even have it in the country. So the private facilities also did not have this medicine at that point in time. There was no possibility of her continuing the initial protocol, like the adriamycin and the cyclophosphamide. Why was that so? Because one of the agents was also out of stock. She received 1 cycle of trastuzumab, and this became out of stock at this instance too. So on review of this patient, she was deemed operable, and I've just referred her to the surgical team for possible surgery. With hope that by the time she gets back to the chemotherapy clinic, we will have some medicines for her to be able to complete her therapy. Thank you. So what are the challenges here? Like I've already said, available funding does not automatically imply ready access to medicines. We've also learned that there can be disruptions to our healthcare systems at any time. Do we really have systems in place to address this? Or have we put systems in place at this point in time to address any other thing that might happen and disrupt our healthcare systems? How about manufacturing, for instance? Have you thought about that? Have you ever thought to say, maybe then as a continent, we can even look at this? I do not know. And then internal procurement processes, I spoke about the emergency micro procurement, but you could see that it was taking even about 2 months. That's too long. And I think we all understand what it means for a patient to miss so many cycles of chemotherapy in terms of disease outcomes. And then frequent stockouts with change to treatment plans, of course, will eventually lead to inferior outcomes ultimately in our patient management. Now, this is quite painful because we are already saying that our patients are coming in at a late stage, and then when they show up, what do we have for them? And then when we have stockouts, it's like a very vicious cycle. You know, someone comes out, but they have such advanced disease that you know that yes, there may be curative, but it would have been better if they had shown up with early stage disease, for instance. And then now they're in your system and you cannot offer them that treatment. It's really a painful place to be. Thank you, Mishka. You can continue. What are the opportunities here? You know, I thought about what we've gone through as a country. You know, in terms of infectious diseases, for instance. Could you maybe leverage on some of the procurement processes for medicines? Could we have an oncology-specific task force, for instance? You know, because, you know, for the HIV team, there really isn't that common to hear that no, there are no ARVs on ground. So there must be what they're doing right, and perhaps we can learn from what they're doing now. How about having some vigorous monthly stock reviews, that no direct purchasing, and then maybe regional procurement instead of trying to get medicines per country, get better numbers. Imagine if I'm here and I'm saying, oh, I need cyclophosphamide, but it's only for maybe 500 people, you know, and then someone might just look and say, well, it's better for me to be manufacturing a different drug than just trying to fill orders for very small numbers in, for instance. Thank you, Mishka. So what really are our thoughts about all of this? Thank you. I'm done.
Thank you so much, Dr. Troto. This is, you know, sounds like what I've experienced myself in, you know, my care for my patients, having to oscillate between protocols, not because of the outcome, but because of the drugs not being available. And I feel your emotion. So it's yes, it's problematic to the patient, as you mentioned, but it is also problematic to the clinician. The clinician gets really demotivated and demoralized. Thanks for sharing that. And I think there will be a lot of you know, questions and thoughts about this. Please put your questions for now in the chat, and we can you know, discuss them and you know, in the upcoming Q&A session. So we now go on to that, and we will have Dr. Mary Nyangasi from Kenya, who will also be maybe responding to some of the questions that you might have. But first, I will invite her to speak and discuss the issues that have come up that have been highlighted in the presentation. I don't know if you have a slide or you just want to speak and weigh in. Dr. Nyangasi.
So thank you. Thank you, John Black, for that introduction. So, and thank you to the speakers who have gone ahead. I think mine was to be a moderated discussion, but I think what I can say that for us in Kenya, what we have done in this area, I think we are experiencing similar challenges as to what Dr. Tlotlo has alluded to in Botswana, and I believe many other countries represented here. But maybe just to speak on how we have addressed the issue of access to medicines. About 5 years ago, we did not have any cancer medicine in our essential lists. So this is something that we prioritized in implementing our strategy. So in our strategic plan, we actually prioritized coming up with an essential medicines list. And as we speak, we have 95% concordance with the WHO essential medicines list. Although as we speak currently, we're in the process of revising our essential medicines list. Maybe also just to mention that the patients also, I like what Dr. Yehoda has presented about other issues that patients really struggle with. Just apart from medicines, we have to be alive to the fact that there are also health products and technologies that patients struggle, especially those with cancer, to access. For example, assistive medical devices for chemotherapy administration, chemopods, stents, colostomy bags, and even diagnostics. So making sure that we have all these items in our essential lists for diagnostics, for medicines, and even for medical equipment. So we really have them available because then it obligates the government to make them available in the national procurement system. So as Dr. Tlotlo has alluded, funding also we've experienced does not mean that medicines will be available. There are usually challenges in the supply chain management. For example, I would speak to challenges with, for example, middlemen. So we have high markups for some of these products. So you find that a commodity, by the time it's arriving at the point of use, is even sometimes double the actual price just because of the middlemen. So it would be better if we could leverage on economies of scale and perhaps have direct engagements with manufacturers. I think having such policies might be more feasible and more sustainable for our low and middle income countries, so that we're able to save our finite resources and reach more and more patients with the little resources we have. Another area that we grapple in the oncology space is the supply chain system is not yet well customized to address issues such as cold chain management. You know, some of the drugs, especially the biologics and the ones for neutropenia, they will require cold chain. So just making sure that along the supply chain, we do not have gaps, so that at the point of use, the quality and the effectiveness of the medication is maintained. Of course, also challenges with stock levels. You find that by the time the manufacturers are bringing in their stocks, even when they have signed contracts to provide some of these, sorry, not the manufacturers, but the suppliers. You know, you go and procure, you get a supplier, and they commit to bring drugs. But when you actually go to implementation of the contract, you find that there may be gaps in terms of availing drugs within timelines. For example, when stock levels reach a certain level and you order, the supplier might tell you they are not able to deliver. And so you find frequent stockouts. especially this is more common with the orphan medicines. You know, the medicines that for the rare childhood cancers, especially some of them, some of these drugs which are not really readily available, you find even when you have provided contracts, you have paid, they are not able to supply for most of the time that the contract is running. And you are actually bound by the procurement laws. You cannot get another supplier until the contract is expired. So these are some of the challenges we experience on the ground. And maybe last but not least, ensuring that even as we are supplying our high, you know, chemotherapy drugs are usually high cost. It is usually very painful when we have to, you know, like destroy medicines that have expired, which if maybe we were able to manage them more efficiently, we could have saved a life. So implementing an efficient system in terms of fast in, fast out, making sure that we redistribute before expiry. I think these are some of the challenges that we see. And I would want to agree to maybe looking at how we can have through the initiatives that are coming in, especially for the low and middle income countries, how we can leverage around regional procurement systems, maybe leveraging on the CDC and some of these organizations that we already have. The African CDC, for example, is a platform where we could navigate around regional procurement system for cancer medicines. Also, what we have been doing in Kenya is looking at how we can adopt mostly from what has worked in the HIV, TB, malaria programs, where they've been able to provide essential medicines zero rated, you know, like they are readily available at no cost to the patients. So these are some of the strategies we are looking at, and because of the costs, really we've been very pragmatic to just come start with a small number that we're able to afford within our budget so that we make them zero rated, and gradually as the funding increases, hopefully target 100% funding and availability of cancer medicines at no cost to the patients. So these are strategies we are working on. Now we are at about 10%, and we hope that we can be able to lobby. You know, when you show that you have succeeded with a small amount you've been given through the exchequer, perhaps then as the funding increases, you are able to reach more and more drugs being made available. The other area that we've been very active around is about discussions with manufacturers, especially for the innovative molecules that are quite expensive, so that we get what we call access programs. So we negotiate prices. We've been successful, I think, as Kenya in, for example, the trastuzumab molecule that used to retail at about $2,000, and now we are looking at about $30. So sorry, not $30, around 30,000 Kenya shillings. I think we can translate that to dollars. But what I'm trying to say is that direct negotiations with manufacturers so that you come up with access programs that can benefit our patients, so they can also access the quality medicines at within the packages, for example, for the health insurance. So these are some of the things we've been able to do. And in these access discussions, we normally don't just talk about the molecule. We also discuss around how we work with the innovator company to make, for example, diagnosis using the immunohistochemistry more available to these patients, because we know that you can have the innovative molecule, but perhaps the diagnosis becomes then a barrier to access the drug. So looking at also even the human resource, how do we capacity build them so that they know how to prescribe these medicines, and we update them to the current practice so that our patients get quality care. Last but not least, we are also alive to the climate change and medicines in the special populations. For example, refugees and displaced persons. In Kenya, we have one of the largest refugee camps in Africa at Kakuma, and these patients also need cancer care. So we are also navigating, working with the UN agencies who deal with the refugee populations, how to access medicines for these displaced people. And also, of course, with the drought and the climate change, how we can reach medicines to the patients affected by drought, and making sure we also address their nutrition, because you can't just give drugs when you don't have food. So making sure even the nutrition aspects are well addressed for the patients. Last but not least, leveraging on already what is available is very important. For example, we have platforms for supply chain management, for COVID in place, for HIV, TB. So we have learned to leverage on what is already there rather than starting parallel systems. So that if it's in terms of say addressing forecasts and quantifications, we use systems that are already in place. We just plug in the cancer aspect. Thank you. Thank you for your attention.
Thank you so much, Dr. Nyangasi, for your input and for sharing how you're addressing these issues from Kenya. Of course, these insights can apply to the neighbors in Uganda, in Botswana, and around. There's been a lot of activity in the chat, and please keep adding there, but there's this issue of regional pools of procurement, and I see Vivian has been weighing in on that, and other people, and this was thought like, maybe you have more bargaining power as a region as opposed to individuals, but also for rare diseases or childhood cancers, for example, you now have a bigger procurement, and maybe you can bargain. Is someone happy to speak about this and any efforts that have happened so far, and what has frustrated them, or these issues, and how we can get to them? Vivian, do you want to speak to that, or Dr. Matei?
Yeah, I can give a quick overview of pool procurement. And so Christopher Lim says that pool procurement really is feasible and depends on political will. And I think that is true. So I just showed the PAHO data. I think they're very clear sort of economic and non-economic benefits of pool procurement. So we've just really talked about the technical challenges of accurate forecasting, technical management of an automated forecasting system for demand planning. We've talked about economies of scale in terms of the numbers. And so I think when you think about all of these things, there's a good argument for pooled procurement, because the challenges that individual countries are facing really can be leveraged and managed through a system, an overarching regional system with technical expertise or technical support. The other thing with pooled procurement is that obviously the economic benefits, and there's not really good data to show it. I just showed you the PAHO data, but there was also data from, I think, the Organization of Eastern Caribbean States at WCC, which showed that pooled procurements decreased the prices of their medicines by 20 to 30%, I think, of cancer medicines. And it's not just pool procurement for cancer medicines. I think pool procurements are just being done globally for other medicines for treatment of common diseases within this region. And so I think it allows for quality assured medicines. It reduces stockouts as well. And I think that, some of the challenges with Dr. Ralefala spoke about, Botswana is a small country. We're seeing 1,000 new cases of cancer patients every year. And so trying to procure for those small numbers and get competitive pricing is almost impossible. And so I think having said all of that, I think there's good rationale and good data to support the fact that pooled procurement in the African region would be successful. And it's not just power, it's the OECS, but I think the key is that it would actually require political will. And, I think Dayo had mentioned about the Afro region being leveraged for this. I think when I think about regional, like the Afro region would be a regional agency that would be responsible for coordinating this and getting sort of technical expertise from different international agencies. So I think that's my pitch on pooled procurement. I think there are now like organizations that are doing sort of mini procurements with different sort of select countries in sub-Saharan Africa, but pooled procurement is really thinking about scaling all of these initiatives with like 4 countries here, 5 countries here for 2 medicines here and 3 medicines here into a much bigger initiative where we're procuring large amounts of medicines. It also allows you to be able to, issue like tenders and like get bids from like large international companies that are interested in actually satisfying some of these bids that we send out. And so I would say that's my pitch. The other thing that I quickly wanted to add was that for the PAHO pool procurement system, there's also a PAHO strategic fund. So this is actually a regional fund that countries can tap into individually. And I want to say it's like low interest rate or interest free, but essentially, so it's not just countries coming up with their own funds upfront, but there's a mechanism to support funding to support countries to actually procure these medicines and pay back later. And so I think pooled procurement would also, paired with like some funding mechanism, like within the region, would actually support more sustainable funding for cancer medicines and other medicines as well.
Yeah, thanks. It sounds hopeful. The political issue, I think, can be very problematic. I just thought about the political coalitions at the regions. For example, the East African Community, which now has Uganda, Kenya, Tanzania, Congo, South Sudan. Could this be a platform to pool? I mean, they've happened on, for example, you get one visa and then you walk through all the countries, but it doesn't seem like the ministries of health or the central medicine agencies are, following with this regional coalition. Do you have a comment on that before Vivian can speak?
I really don't. I think I'll just let Vivian speak, or maybe Dr. Nyangazi can comment on this. I think when you think more about Afro region, I think it's more sort of it's not really within my domain. I think the way of health think about this would probably be more critical in thinking about conversations that Afro has initiated. In the absence of an Afro thing, I think regional based on, like East SADC is reasonable, but I think really thinking about the number of cases that are diagnosed in Africa overall, I think a pooled procurement for the region is what's going to be most effective. Like the more countries we get, the more price reductions we can also negotiate.
Thank you, Ehud. And maybe just to mention, I think there is actually opportunities in African countries leveraging on the economic blocks that we have, like maybe organizations through like Africa CDC, East African Community, SADC, and so forth, to bring this to the desk of the health ministers, especially as they are attending discussions around health in these meetings. And it is something that we need to advocate within countries so that some of these agendas are presented during the meeting. So it will take a lot of advocacy within the health ministries. And I think it's something that's feasible. And just to add, apart from the pooled procurement, what we see in the oncology space is challenges in the area of regulation and pharmacovigilance of a number of products, especially biologics. We do not have capacity in many countries to effectively regulate biologics. And so having a system at the regional level will be more cost effective for most of our countries. So it's an agenda that's feasible, but will require a lot of advocacy. Thank you.
Thank you so much for weighing in. I wanted to have Vivian speak briefly, and then I invite Benda to also speak.
Thanks, John Black. This is a topic that's very close to my heart and, well, my day-to-day job. So the thing about pooled procurement, I think there are good intentions. Everyone is convinced that it's the way to go. It's operationalizing it. And what we see is 2 or 3 key things. One is financing. The fact that a lot of large procurement in Africa is done by governments individually and not by sort of a centralized fund, the way you have the PAHO strategic fund or a global fund in HIV. The second thing in financing is around something called a letter of credit. This is a document that's issued by a government to a manufacturer that states that this government can afford to pay for these products. Now, in different countries, you find letters of credit taking anywhere from 3 months to 9 months to be issued. Without that document, a manufacturer can't even start production. So that's another challenge that we are seeing with large scale or government related procurements. And then the third thing that I wanted to say about financing is out-of-pocket payments. In some countries, there is no single government purchase for anti-cancer drugs. So you have patients running all over the place trying to look for drugs. And of course, you know, this is not aggregated into any single procurement channel. So what are my thoughts? How can we deal with the financing issue? I think we have an opportunity potentially with banks. We know that, for example, in COVID, the Afrexim Bank guaranteed country procurements. And because of that, countries were able to access, you know, in bulk and at lower prices. So potentially that's one way we can approach the fact that payments are delayed by governments or sometimes are not available year on year from any particular country. So that's financing. The second thing is regulatory, and I commented in the chat. Regulatory bodies are, you know, they are checklists, they have checklists and they will follow them to the detriment of access. And so, yeah, how I think oncologists and cancer control programs need to come together to actually advocate to regulatory bodies. Yeah, in terms of like how long it takes to register products. There was about a year ago, maybe 2 years ago, there was a body that tried to do centralized procurement for SADC countries, so Southern Africa countries. One challenge that there were some operational issues, but I think one of the issues was if a product is not registered in a country, how will it be brought in? Under what mechanisms? And so all those are processes that really hamper the whole good intention of pooled procurement. And then lastly is, I think that's about it. There's need for people to come together and have conversations with the operations or the operational facets of pooled procurement. I think that's the only way we can even start to even just putting in place internally pooled procurement, hospital from hospital. So there's a country where there are about 6 different cancer treatment centers, and each of them is procuring on an individual basis. That there's inability to come together even within the country to purchase jointly. So that makes country pooled procurement that much more difficult. So in-country coordinated procurement first, and then and which is what we at CHAI are trying to do before we then go out across countries. Over. Thank you.
Thank you, Vivian. Over to you, Benda.
Okay,
I
so
understand
thank
you
you
also
so
had
much.
some questions. Yeah, go ahead.
Sorry, thank you so much to all the speakers. And I think mine is not to speak, but to co-moderate the session, at which point there was some number of questions that came up, specifically starting with the disproportionate nature of access to medicines, and which Dr. Matei mentioned from the start, that we have 60% of diagnosis happening in lower and middle income countries, and then 5% of programs, access programs actually being in those low and middle income countries. And then Vivian, from just the last speaker, Vivian has brought up very pertinent issues around the complexities of procuring in country, across countries, in programs, and having access to medicines, not just about the issues that were raised about quality, transparency, complexity, but also coming to the issue of financing for affordability, or even financing for access. So the question that I would want to put to the two representatives who spoke, Dr. Tlotlo and Dr. Nyangasi, who are operating from two very different settings. One country, Botswana, has full financing for their medicines and for their healthcare system. The other one is Dr. Nyangasi, who is coming from a point of having to negotiate against other government priorities, such as drought and refugees. If you could, the two doctors, if you could speak into the issue of getting political buy-in, because I'm looking at the question of, there are people on this call who may want to do something in country, even as we look at regional procurement processes, navigating the in-country first before they get to the level of global, regional or global. We'll start with Dr. Tlotlo. What would you say has been the biggest enabler in working with your government towards getting access to medicines in the region? Thank you. You're muted, Dr. Tlotlo.
Thank you. Yes, yes. Well, I think what I should mention is all the way from childhood, most of what we have access to in Botswana has always been funded by government, right? So it's not just healthcare, it's stuff like schooling, for instance, all the way from primary school, tertiary education. So most of this has been paid for by the government. Now, I don't think then that it's actually a very challenging thing to say to policymakers, listen, I need access to all these medicines and stuff like that. But now the big question then is, what exactly then is the clinician on ground asking for? Dr. Matei earlier on spoke about whether really what we are getting is what we need for the majority of the patients, and we're going to have better outcomes with it at that point in time or not, right? So what do I mean? Why should I find myself at a point where, yes, funding is there, but I don't have the basic drugs, and maybe I have the molecules, and maybe I have drugs for patients who would use them in the palliative setting more, right? So it goes then back to saying, are the clinicians really working closely with the procurement teams? What data is the clinician following at that point in time? Because this is extremely important, what I find to be extremely important in my setting at this point in time. Because really, if it's money, like I told you, I was shocked, right? Because I mean, we said, oh, there is no medicines, and the question was, can you sort it out if I give you funds, right? And we say, yeah, we can do that, only to learn you won't have your medicines in a week's time. There is a whole lot more that goes into this process.
So what I'm hearing from you is, besides the financing for the access to the medicines, there is the need to what Dr. Matei called prioritizing the priorities in country so that you're able to gauge what really is the priority on the ground for the clinician to meet the need for the people. But Dr. Mary has been working in Kenya, where on the other hand, we have the issue of even competing priorities amongst government agencies. And yet, Dr. Mary, you've been able to get 25 drugs on free access to patients in public sector. How did you do that? Could you give insights to someone who wants to take out today, this is what I'll start to get political goodwill in my country? Dr. Mary.
So thank you, Brenda. And I think what I can say is that you really need to get leadership aligned. Without the leadership on your side, you really cannot achieve much. So, and when really you get the leadership on your side, it will take a lot of lobbying. I want to just remind us that what we are doing in the cancer space, access to medicines, the challenges we face, is not a first time. It happened some time ago for HIV medicines. It took a lot of lobbying and advocacy. And in fact, the HIV civil society is accredited for what then led to what we see now, where HIV medicines were made freely available to all patients. So I think there is nothing that is so out of the world for us. It's time that maybe also our civil society can proactively take on the center stage and advocate so that we reach that movement that change the narrative for the HIV patient. That is number one. Then number two, the leadership will want to know then what will it take. So having a strategy, having a plan, a strategic document, a cancer control plan that you will say, for us, if we are to provide medicines, this is what we will need to do, and this is what it will take, and this is the cost. So having a plan and also data that speaks to it, so that you're able to quantify your needs, you're able to focus, and you're able to actually give evidence-based kind of discussion when you are lobbying for funding. So I think for me, these are the most important. The leadership has to be aligned. You must have a plan, and it has to be evidence-based. And let us also challenge ourselves as civil society to do what, I want to challenge the civil society to do what happened in the HIV space just a few years back when they had all the strategies and they had the plan, but there was no money. It took a lot of lobbying and a lot of advocating because I've listened to Vivian speak about the challenges with financing the banks, the Exim Bank, and the letters of credit. I tell you, when the health minister decides this is a priority and they take it to cabinet, they can even come up with regulations to surmount some of these challenges, and we will start seeing a difference. Thank you, and over to you.
Thank you, Mary.
Brenda?
And I wonder.
Oh, sorry.
Yes.
I was going to comment.
Go ahead, Dr. Matei.
Yeah,
yes,
I was going to comment quickly. I think the really good points raised about advocacy and political will and the fact that this is not a new landscape that we're like really dealing with. This was done with HIV. And I think it's actually really important to emphasize that because I think in the end, patient advocacy has really led to a lot of strategic changes and political wills to address a lot of things. We did a qualitative study recently where I think one of the patients said, cancer stockouts, drug stockouts are taken for granted. Can you imagine if an HIV drug was out of stock? It would be all over the newspapers. And I think it speaks to sort of how we are prioritizing cancer and HIV and that landscape. It was never set, like 10 years ago, we're having a different conversation. So I think it's really about leveraging patient survivors, like communities and just like the lay public to actually push for advocacy of cancer medicines to be considered in the same vein. Because like Dr. Nyangazi said, we can provide the funds for it if there is political will. And I think that's where there's a critical gap right now, is that it's not really considered in the same vein. And unfortunately, in some African countries, a lot of people who are wealthy seek cancer therapies outside in terms of, people in government. And so there's really not an incentive to make the system better in general for the whole population. I mean, it speaks to a lot of, inefficiencies within the system, but I think there really needs to be a galvanizing of the general public to really prioritize cancer and the different aspects of it that can be dealt with. But we've done that in HIV, so I think it's possible to do that with cancer as well.
Thank you. In the interest of time management, and thank you so much, Dr. Matei, thank you so much, Tlotlo and Dr. Nyangasi. In the interest of time, and because there is just one thing, there is a lot of global movements for various disease areas in cancer. And we're seeing a lot of talk around cervical cancer elimination, around the breast cancer initiative, the childhood cancers initiative. There is now the ATOM that was announced in the UICC World Cancer Congress. In maybe one sentence for each one of you as your closing remarks, would you give us what you think Africa could do beyond the pooling for resourcing for Africa? What else could we do in our own individual countries to ensure that we take advantage of the global movements and the call to action for elimination of some of the cancers? Tlotlo, we start with you in one sentence.
Thank you. My first thing, honestly, would be political will, political will, political will. It's one sentence.
Thank you. Political will, and Mary has spoken at length about what to do around that. Yehuda.
I would say breast cancer and cervical cancer are good initiatives to target because of the prevalent incidence, sort of looking at that curve that I showed you, sort of high cure rate, highly prevalent. And I think if we can do that effectively, I really think we should be prioritizing those two disease areas in African countries. If we can do that effectively, then I think we'll have a spillover effect and lessons that we can learn and extrapolate to other cancers.
Thank you so much. Dr. Mary Nyangasi.
Thank you. Mine is just to advocate that we have a plan. We work on having cancer control strategies across various countries so that now when we go to lobby and we are asking the politicians, we exactly know what we want to do. And I think if we can do it together and we are all clear on what we want to do when we get the money, it will really make a difference for the patients. Thank you.
Thank you so much. And I think for the three speakers, for all of us who are listening in, something stood out. One of them is that to create a movement, both Afro-region as well as in our own countries, we need all actors on the table. So advocates in civil society as well as advocacy in policy levels. We also do need strategies. Dr. Mary, thank you for that. We do need data, Matei has mentioned, so that we're able to track our priorities. We do need to have political will. Tlotlo has mentioned since childhood, her government has provided the services that ought to be rightfully provided by the governments, and therefore we commend you for that. And lastly, I think on this call, we've heard that everybody says we do need political goodwill, but also regional coalition building. And Mary has given us the formula. Let's start with strategies at home. I want to give it back to Charles so that we honor the space that we are in, and we also honor the time that you have to go back to other engagements as well. Thank you so much for all our speakers.
So thank you so much, Beda. I'm Charles from the Africa Cancer Eco Hub, and I would like to thank you so much for joining us today. And thanks to our speakers for quite informative discussions, a lot of takeaway points. And I think we all learned something. So we are going to share the recording on Basecamp. And in case you have anything else, you want to continue the discussions over there, you can post an article that you would want maybe the community to learn about. You are free to do that. So our next session will be on December 15th. That is a month, 4 weeks from now. So we'll be focusing on integration of survivorship at the policy level, integration of cancer survivorship at the policy level in Africa. So we are going to be sharing the agenda in the coming weeks. So look out for that, and we hope that you will be able to join us so that we can continue running So otherwise, thank you so much, and I wish you a good time. And I think it's bye for now. Thank you.
Thank you, everybody.
all.
This was fantastic. Take care, everyone.
Thank you.
Bye.